For this component, we have organised for some of our PhD fellows and postdocs to be giving you some presentations on their work. And I'm not sure how much you've heard about the structure of MCAS, but we have different streams within it. And so you're going to be hearing this today about people who've been doing work in the primary care stream, in the rural and regional stream, and I think what's our last one? I've forgotten already.
The pharmacy and primary
pharmacy
care.
Yes, so primary care. So Jaclyn Bishop, I'd like to introduce to you. She's quite a senior pharmacist who is also the PhD fellow in the rural and regional hospital stream, where there's obviously in Australia a lot of hospital care in the rural setting is provided by primary care physicians, which is where this fits in. So Jaclyn's presenting from Ballarat, which is, what is it, about an hour and a half drive or 2 hour drive from here. So this is a real feat of technology, but we've done it before and it worked before, so we're crossing our fingers this time. So we'll introduce you to Jaclyn, and she's going to tell us a little bit about what she's learnt about AMS in the rural and regional setting. So welcome, Jaclyn.
Thank you, Kirsty. And apologies that I can't be there today to meet with you all in person, but I hope that you've enjoyed the session so far. So I wanted to try and, I suppose, highlight the primary care aspect of the work that we've been doing around the rural and regional setting, and highlight what we've learnt so far and potentially where there are some gaps that may need to be addressed. So the presentation today will look at health inequalities for rural Australians and why that's important. The rural GP practice settings and how that might differ from GPs that work in a metropolitan centre. What are some of the influences on rural GP engagement with AMS programs and some of their prescribing habits? Some strategies that we can propose for rural GP engagement, and then hopefully at the end there'll be some time for some general discussion about the presentation and the way forward. Just to begin, over 8 million Australians live outside of greater capital cities, and it might surprise you to know that that's about 30% of our population. So a third of the population are outside of major cities. And as you'd be aware with the country that we live in, that can be quite a long distance that people are living from capital cities as well in terms of travelling for care. So more and more, the rural health services are trying to provide as much care as they can close to home. But with that comes some challenges as well. There is data out there about the health inequalities that do exist for rural Australians. So one example of some work that was published in the MGA a few years ago showed that there was a 7% higher mortality for rural cancer patients compared to their metropolitan counterparts. And when they did the analysis over about 10 years, that equated to 9,000 deaths, which I think you'll agree is quite a significant figure and something that we want to be doing something about. And this data was sort of the birth of the regional cancer centres that you may be aware of. So there is one here in Ballarat, and other larger regional centres do have regional cancer centres and then spokes out to the smaller communities. So it is something where data has been able to drive some practice change for rural Australians. In terms of infectious diseases, the Australian Atlas on Healthcare Variation, second edition, listed 2 infectious diseases for topics of discussion. And both of these, I think, as you'd recognise, are non-communicable infectious diseases. But they talked about the differences in outcomes for patients with cellulitis and kidney and urinary tract infections. So just from this slide, I'd just like to highlight some data that you might find interesting. So this snapshot there is the number of potentially preventable hospitalisations for cellulitis specifically. It's per 100,000 people. So you'll see there's the categories of remoteness that are used to classify. So major city, inner regional, outer regional, and remote and very remote are combined. And then there's information about the socio-economic status of the patients from level 1 to 5, where that's provided. And then down towards the end, some of those categories have been combined together. But just drawing your attention to where the 2 arrows are pointing. So for someone who lives in a major city hospital from a low socioeconomic status, their rate of preventable hospitalisations for cellulitis per 100,000 people is 228. If you go to a remote classification, for someone who has the same socioeconomic status, being low, their rate of preventable hospital admissions for cellulitis is 785. So 2.5 times what it is someone living in a major city. And you'll see from that data that as you move across, that the rate of preventable hospitalisation increases for the same socioeconomic status, from going from inner regional to outer regional to remote, where it is the most extreme. So there certainly were some strategies included within the Australian Atlas of Healthcare Variation about how this could be addressed, but there's certainly gaps on why this might be the case that need further examination. But as I've said, it's one example of where there are some health inequalities in the infectious diseases space. Some work that we did was having a look at the Hospital National Antimicrobial Prescribing Survey data, or the NAPS data, and we compared the data for major city hospitals with a collated group of data from hospitals that were in inner regional, outer regional, remote and very remote classifications. So it was two broad groups. But what we did find from this data was that there was a higher rate of inappropriate antibiotic prescribing for those orders that came from regional or remote hospitals. And there were a couple of conditions where there were also differences that were of note. So cellulitis, are particularly of interest. There was a higher rate of inappropriate antibiotic prescribing in regional and remote hospitals. Ceftriaxone, although the results across the board weren't particularly good, they were a higher rate of inappropriate prescriptions for that particular agent. And there were also some high-risk infections that were also had a higher rate of inappropriate antibiotic prescriptions. So sepsis and empiric therapy for sepsis were two, and endocarditis was another one that was highlighted. So this data really emphasised to us that there may be some particular areas where regional and rural hospitals need greater support with their antibiotic prescribing. How does this relate to primary care? Well, we know that rural GPs work in multiple health settings. So this is a statistic that was in the Health of a Nation report that was released by the RACGP last year, which estimated that 41% of GPs in regional and rural areas provide care in 2 or more health settings. And that's compared to just 20% of GPs in metropolitan areas. And those other care settings could be a public hospital, most often in a rural area, where they have admitting rights and provide care for the patients in those smaller facilities, or it might be a multi-purpose centre if it is a smaller community. They also might be working in an aged care facility, quite often co-located with a multi-purpose service, and then they've got their private practice as well. So they do need to be juggling their time and their care of patients across multiple settings, which, as you can imagine, can be quite a challenge. Through our work with undertaking focus groups and key informant interviews with really key people that are involved in AMS programs in this country, and also quite a number of clinicians that work at the coalface trying to implement AMS programs in regional and rural hospitals, we're able to identify some key factors that impact on how sustainable an AMS program is, or its ability to have an impact on its prescribers. And I've just put out a couple of things to talk about in more detail, the ones that I think relate particularly to primary care. And just to say that we did have a couple of GPs that were involved in this work. Not a lot. They are difficult to involve in this sort of work, but certainly they had some suggestions on engaging them with AMS programs and why their prescribing habits may be in certain ways. So the first one there is a culture of independence and self-reliance. So we know that GPs that work in rural and regional areas really have had to be independent in their decision-making and self-reliant because there's been no one else there to assist them. They quite often work in sole practices or practices where they share the sessions, so they're not actually in the practice with another GP at the same time. So they've had to become very adept at making their own decisions and being confident in the decisions that they've had to make. And from an AMS perspective, that can be difficult when you are trying to come in and provide advice to a GP that's used to making their own decisions, and thinking about how you might influence them to consider that the advice that you're providing them is relevant and worth implementing for their patients. So certainly the other thing that comes up around the culture of independence and self-reliance is this sense of isolation that can appear, and that can be from I suppose a mental health perspective in terms of isolation. It can be from a professional perspective, and it can also be from the ability to receive feedback on your prescribing from your peers, and that might be a formal feedback, or it could just be that tea room conversation or water cooler conversation about a particular patient and how you manage their infection, and comparing that to what your peer might say about how they would have managed a certain situation as well. So certainly that is something that is more challenging to deliver to primary care GPs who are working in the regional setting. The other thing that came out about a culture of independence and self-reliance is that GPs have had to create their own networks and their own sources of seeking advice where they really have felt that they needed another opinion. And the feedback we received was that they're more likely to call a physician that they're familiar with and that they've had a relationship with over a period of time, rather than an infectious diseases physician who they may have just met, or they may have just met occasionally and haven't had the chance to develop a strong relationship. So one of our ID physicians commented that building that relationship in the rural setting has been a little bit more difficult than it has been in the metropolitan centre, where they're certainly dealing with hospital physicians that are used to having that team-based approach. The second point there is about personal relationships, and this can be a positive and it can be a barrier in rural communities. So we do know that rural GPs are very invested in their community. They're quite often, as I said, working across multiple care areas, and they know their patients both medically, but they also know them personally as well. So they can be very open to change and to receiving information on how they could improve the care of their patients. So tapping into that investment in their community and that desire to really improve the community's health is something that can work in the favour of any antimicrobial stewardship practices that you might be looking to introduce. The flip side of that, however, is that personal relationships can impede the ability to provide feedback. So if potentially you're looking to engage a practice nurse who might be doing some data analytics on their practices prescribing, their ability to provide feedback to the GP could be impacted by the fact that they may then also see that GP in a medical perspective as well, or it might be the nurse from the aged care facility ringing the GP that also sees that GP as their primary GP as well. Having those conversations can be difficult when you've then also got to have that relationship with them as their GP. And how it's been described to us is that it's not as easy as saying, well, I'll just go see another GP. It could be hundreds of kilometres until there's another GP that you might not have that working relationship with as well. So it's certainly something to consider with GPs. Geographical location also has an impact, and it can impact from a number of different factors, but probably the key one is having access to the information that the GP needs to make the decision really there and there for the patient. Because advising them to come back the next day or in 2 days' time when the tests have finally come back from the laboratory is often not an option for patients that generally come in only to the GP when they're really quite sick from their farms or other remote locations, and they really do need their therapy to be considered while they're there, because the chances of them coming back again, is impractical to say the least. The other thing as well is that if you're looking at delayed prescribing type interventions, you need to think about how easily the patient's able to access a pharmacy. It might only be a depot pharmacy that's open or available at the same time that the GP surgery is there as well. So it might not be that easy to access medications at a period down the track. The other thing that came up in some work about geographical location was perhaps some of these concerns about patients not coming back and needing to provide the treatment there and then might actually be perceived rather than real. And there may be ways to work around that and not necessarily choosing the broader spectrum agent might not be the best approach, and there may be other ways to look at it. So I guess that's been built up over a long period of time, and needing to work with the primary care GPs to work out other strategies that might work. So you might be able to implement delayed prescribing, but the patient would need to access the medication there and then and have it at home, and potentially phone in or telehealth in to get advice on whether they should take the medication. The final one there is about understanding the local context, and there are different antimicrobial resistance patterns in different communities, as you're aware. And the discussion has really been about how does the GP access that information so that when they're making antibody choices, they're making those that are appropriate to the context and the local environment that they're working in. And one of our GPs was very clear in saying, I've got no idea on how I would access that information when I'm in a rural community. Also some feedback that potentially when GPs that are engaged in AMS programs and calling larger hospitals for some advice, that potentially the people they're calling may not have access to information about the local context as well. So it's a really important area to consider. So what are some strategies for rural GP engagement with AMS? And these are really just some suggestions or some considerations. But it's been very clear with the work that we've done that relationship building with consistent staff is incredibly important. So building those relationships, if the ID physician is constantly changing, or the pharmacist that's involved with providing support is consistently changing, turnover of nursing staff, that can be really detrimental to those relationships and therefore impact on the advice. Reducing professional isolation is certainly important as well, and strategies to achieve that in the AMS space is also very important. Suitable benchmarking or ways to provide feedback is something that needs consideration, and really being able to find GPs to be able to benchmark with. And we have the GP NAPS, which I suppose is a starting point from that, but my understanding is there hasn't been many rural GPs that have been involved in that at this stage. So really some support to encourage rural GPs to be a part of GP NAPS, I think, would be something important. That way we know that we're providing them feedback that is relevant to their particular environment. Point of care testing may help, where point of care testing is able to provide results more quickly than what a laboratory test may. I've mentioned about tailoring delayed prescribing and to make sure that that actually fits with the rural environment. An essential repository of local information, so antibiograms and other information about local infectious diseases would be useful. And where it's required, formalisation of relationships so that the GP, when they are admitting patients and providing care in the hospital environment, they know who it is that they can contact and who's got the information about their local setting. Just to finish, two final comments. This is a project that I'm working on at the moment. It is around cellulitis, so I hope that some of the data that I've showed has highlighted why this is an important area for consideration, and particularly in regional areas. But we've been working on designing a cellulitis bundle of care that will be implemented in 3 hospitals in the Western District of Victoria. So Ballarat Health Services and Wimmera Healthcare Group. But importantly for this conversation, it does involve Colac Area Health, which is a health service that does have GPs providing services to them. And through that process, we have been able to engage with their GPs and get feedback on the tools that we're considering, and hoping that these tools will be able to provide them with some guidance on diagnosing cellulitis, when they need to seek advice, when there's particular warning symptoms, and also what other contributing factors to consider in their patients and what sorts of things you might do to try and mitigate those predisposing factors where possible to prevent the recurrence of cellulitis. So it's been really great that we've been able to have this multi-site work and co-designing it with a number of different health services that have different structures and different medical staff providing the services. I know you won't be able to read any of this, but on one side is the tool that we've developed, the front page there. It's a multi-page tool, and the pages that are there are the considering differential diagnoses and also looking for danger signs. And then on the other side is a leaflet that we've developed for patients to really help them understand what cellulitis is, what to expect while they're in hospital. On the flip side of this leaflet is some self-care advice for when they're home so that they can continue the treatments that have started in hospital, but also some strategies to prevent recurrence as well. The other thing that we've been thinking about is really this alignment between GPs that work in private practice. They have their rural hospital practice, they work in aged care, and they're also interacting with the community pharmacy, who may be the ones that are actually providing the services to the rural hospital and the aged care rather than the in-house pharmacy department. So how could we structure an AMS program that actually goes across all of those different practice environments, rather than having silos where you have a hospital program that really only thinks about the hospital? Aged care might have some AMS things in place, but it's not necessarily the same as what the rural hospital is focusing on a particular week or a particular month. So just making sure that the messages that are being provided to GPs are consistent, and if you're going to be talking about certain issues, to make them a particular focus at the same time point rather than having them misaligned. And you'll hear more about the community pharmacy interface with the presentation later on today from Jaclyn. So in conclusion, I feel that AMS in the rural regional primary care setting is an emerging topic where we're learning more and more. But the take-home messages are that rural GPs do work across multiple health settings, and therefore our approach needs to think about those dynamics. To have an integrated AMS support across the hospital, aged care and private practice settings in rural communities, I think would be incredibly beneficial and something that we'd like to pilot. Also looking at support to reduce the isolation of primary care GPs in rural areas, help them to build relationships, and also help them to access local antibiotic resistance data. And finally, to support them to become involved in quality programs such as the GP NAPs, so that they've got some data that they can use to benchmark their practices. So I'll leave it there, and if there's time, I'm happy to take any questions or happy to hear any comments from the group. Thank you.
Leslie Hawes is asking a question, Jaclyn.
Hi, Jaclyn. I'll have a video of the room. You said that cellulitis tool was also for patients. Is that true? If it